Hello and welcome to the Continence module. My name is Dorothy Doty. I'm a certified wound-ostomy continence nurse, and I'll be the videotaped instructor for much of this module. In order to understand continence issues, both urinary incontinence and the different types of voiding dysfunction, you first have to understand what is normal. That's the basis for understanding what can go wrong. Is the basis for conducting an appropriate assessment, and is the basis for providing appropriate intervention. So in this class, we're going to go over normal voiding physiology. Controlled voiding is complex. We don't think about it as something that we do automatically many times a day, and we never really think about, you know what, this requires coordination among multiple structures and neurologic pathways until we have a problem. And then the complexity starts to become much more obvious. Incontinence can occur because of major damage to one component of the continence system or because of minor damage to two or more components. When you look at voiding, there are two major phases of the voiding cycle. You know this. There is the storage phase. And if anything goes wrong in the storage phase, if the bladder malfunctions and loses the ability to stretch and store normally, if the sphincter malfunctions and loses the ability to maintain a watertight seal, if something goes wrong in the neural control system, then problems during the storage phase are manifest as incontinence. So that's when people say, you know, I'm running to the bathroom all the time. I feel like I can't hold much urine. Sometimes I don't make it. That's what's involved when you hear women say, when I go to the gym, I leak urine. Those are problems that occur during the storage phase. Problems with storage result in leakage. The other component of the voiding cycle is, of course, the emptying phase, voiding itself. And if there are problems during the emptying phase, then it's manifest as urinary retention, incomplete emptying, also known as voiding dysfunction. So this is when you hear a patient say, it takes me a long time to empty my bladder. I'm not really sure I ever empty all the way. I always feel halfway full. And obviously, strategies to address continence issues would be very different than strategies to address voiding dysfunction and retention. Now, as we go through normal function, as we go through assessment, as we go through management, you will find attention to three major systems. First of all, the neurologic system, all of the neural structures and pathways that control voiding and control storage. Secondly, the bladder itself. And finally, the sphincter mechanism. So that's what we're going to look at as we go through. We're first going to look at neural control, then we're going to look at the functions of the bladder itself, then we're going to look at the functions of the sphincter itself. So let's start at the top. Let's start with neural control, which actually starts with the cerebral cortex. Now, many times when people think about problems with voiding, problems with continence, they immediately focus on the bladder and on the sphincter. But many times the issue begins much higher. It's a problem with neurologic control. When you think about neural control of voiding, you want to think about the cortex as being the highest level of control. Sometimes I compare the cortex to the CEO. Then you want to think of the midbrain as kind of the administrative assistant or the next level down. So the CEO makes the decisions and hands off to the midbrain, to mid-level directors, mid-level administrators. You come down one more level and you're at the level of the pons. And the pons is the frontline supervisor. The pons actually hands out directions to specific neural pathways that either support voiding or support storage. So let's start first with the cortex. The cortex is the CEO. The cortex provides you with social continence. And when I say social continence, I mean the ability to decide when and where you void. If you have normal control, you can initiate voiding even when you have very little urine in your bladder and no sense of urgency. For example, if you go for a physical exam and they say, give me a urine specimen, and you just voided 40 minutes ago, most of the time you can give that urine specimen because the cortex can activate the pathways or hand off to lower level structures that activate the pathways that make the bladder contract. If the cortex is in control, you can also delay voiding when you are very full. You've all had that experience when you are so full that it's painful. And all you really want to do is pee. But it's not appropriate because you're in a meeting, because you're in a car, because you're on a plane, and you hold it until you get to a suitable place to void. That's what the cortex provides. Social continence, the ability to decide when and where to void, to initiate voiding when you don't have to go, to delay voiding when you have to go really, really badly. Now, that decision making by the cortex is based on sensory input that is processed by the midbrain. The midbrain, the main function or the main structure in the midbrain is the PAG or periaqueductal gray. And what the midbrain does is it receives sensory input. So it gets input from the bladder that says, I'm really full and I really have to go. But it also gets environmental and social input that says, yes, the bladder's really full, but I'm sitting on a plane. The bladder's really full, I'm in a meeting. In that case, the cortex is going to decide, no, you do not void. So the responsibility of the midbrain, the periaqueductal gray, and other structures is to gather input both from the bladder and from the system as a whole, to process that input, hand it off to the cortex, the CEO, and wait for a decision. And then to implement the CEO's decision. So decision making, the responsibility of the cortex, but the cortex bases that decision on input processed and delivered by the midbrain. Controlled voiding, continence, is a learned response. We weren't born continent. We had to learn how to recognize the sensation of bladder filling. We had to learn how to control our pelvic floor muscles so that we could delay voiding till an appropriate time and place. Clearly, continence requires normal cognitive function. So when we have patients who have advanced dementia, one of the things that happens is they lose social continence. The bladder continues to empty, but you lose the ability to decide when and where to void. And they void in very inappropriate places. So let's take this process and walk down the pathway. So it said, okay, the cortex has decision making and it will use input provided by the midbrain, by the PAG, to determine whether you should or should not void. If the decision by the cortex is no, you should not void at this point in time. If it's a stop sign, then what happens is the CEO says to the midbrain, no, do not let the bladder empty. Keep storage mechanisms in place. The PAG in turn turns around and says to sinners in the ponds, no, no voiding. Continue to maintain the bladder in storage mode and the sphincter in closed position. But if the midbrain says to the cortex, the bladder's really full, this person is passing a restroom in less than 60 seconds, then the cortex may very well say, okay, this is a great time to void. Then the cortex says to the midbrain, okay, activate voiding as soon as she reaches the restroom. In other words, the CEO, the cortex, has given the midbrain permission to activate the voiding sequence. In turn, the midbrain hands off to centers in the pons to activate voiding. So I want you to think at this point, cortex equals CEO equals decision making equals social continence. That's the big picture here. Any damage to the cerebral cortex can compromise social continence. Okay, so now let's come down to the pons. So we've talked about the cortex, the CEO. We've said the midbrain kind of funnels information to the CEO, takes decisions made by the CEO, and hands off to the operational supervisors. And those operational supervisors, those frontline supervisors, are located at the pons. The pons actually has two major centers. The pontine storage center, which obviously is active during the storage phase, and the pontine micturition center, which is active during the voiding phase. So let's talk first about the pontine storage center. So let's say you are on a plane, you are in a meeting. Your bladder is pretty full, but the decision's been made by the cortex, delay voiding. Hand it off to the midbrain, the PAG. PAG turns around and says to the pons, no voiding now, maintain all organs, all structures in storage mode. What actually happens? How does that get implemented? How is it that you continue to store even though you really, really have to go? So the pontine storage center has several nerve pathways that it controls. The first is a set of nerve cells in the sacral cord that are known as Onuf's nucleus. Now, we're not going to ask you Onuf's nucleus, but I do want you to know that the pontine storage center controls this group of nerve cells in the sacral cord. When those nerve cells are stimulated, they in turn activate the pudendal nerve, which maintains closure of the voluntary striated sphincter mechanism. So when you're tightening up, how are you doing that? Through the cortex, activating the pontine storage center, activating a group of nerve cells in the sacral cord, activating the pudendal nerve, and you contract the sphincter. Also, during the storage phase, the pontine storage center activates the sympathetic nerve pathways. Sympathetic nerve pathways to the bladder neck increase contractility, which maintains bladder neck closure, and sympathetic stimulation of the bladder wall keeps the bladder in a relaxed state. Now, it can be confusing to think that sympathetic stimulation tightens the bladder neck and relaxes the bladder wall, but it has to do with the type of nerve receptors located in the bladder neck versus those located in the bladder wall. So in the bladder neck, you have alpha adrenergic receptors, and they respond to sympathetic stimulation by contracting, which closes the bladder neck. In the bladder wall, you have beta adrenergic receptors, and they respond to sympathetic stimulation by relaxation. So you can see that the pontine storage center has access to all three components that are critical to storage. The ability to maintain the bladder wall in the relaxed state, the ability to keep the bladder neck tight, and the ability to maintain the voluntary striated sphincter in closed position. Okay, now let's talk about what happens when the cortex says, this is a good time, hands off to the midbrain, says activate voiding. The midbrain turns around, activates the pontine micturition center. That's the other half of the voiding centers in the pons. So you've got the pontine storage center, the pontine micturition center. When the pontine micturition center is active, First of all, it will shut down the sympathetic pathways. Remember, the sympathetic pathways were keeping the bladder in a relaxed state and the bladder neck tight. So once you shut down sympathetic stimulation, you start to get bladder neck relaxation, preparation for voiding. Secondly, it blocks nerve innervation to that group of nerve cells in the sacral cord, to onus nucleus. Once you shut down stimulation to onus nucleus, you shut down activation of the pudendal nerve. Now you get relaxation of the striated sphincter mechanism. And finally, the pontine micturition center activates the parasympathetic pathways, which cause bladder wall or detrusor muscle contraction. So just like the pontine storage center has control of all three critical areas, bladder wall, bladder neck, and voluntary sphincter, so does the pontine micturition center. When the pontine micturition center is activated, the voluntary sphincter is relaxed by interruption of stimulation to onus nucleus. The bladder neck is relaxed by interruption of sympathetic pathways, and the bladder wall is stimulated to contract. The end result is what we call coordinated voiding. What do we mean by coordinated voiding? It means that the voluntary sphincter relaxes, the bladder neck relaxes before the bladder wall contracts. So you want your sphincters open before your bladder contracts so that you have unobstructed voiding. So what I want you to think of at this point, the cortex, the CEO, makes the decision. Makes the decision based on comprehensive input, a total situation analysis provided by the midbrain, the periaqueductal brain. The CEO, cortex, makes the decision, hands it off to the midbrain, the periaqueductal brain, which in turn activates either the pontine storage center or the pontine micturition center. If the pontine storage center is activated, sphincters stay tight, bladder wall stays relaxed. If the pontine micturition center is activated, sphincters open and the bladder contracts. That's it in a nutshell, and that's critical. That coordinated voiding when voiding is desirable, storage when voiding is not desirable. So I know that a lot of this is new information. I know it can be very confusing, but you want to get clear on the very basics. Decision making at the level of the cortex, data analysis, data synthesis, and handoff on decision making is handled by the midbrain. But when it comes right down to controlling the critical pathways, it's at the level of the pons. You have the pontine storage center, the pontine micturition center. You want to be very clear about that. Okay, so now let's come down to the spinal cord, because when you think about it, all of the decision-making centers, mid-level supervisors, frontline managers are at the level of the pons and up. But the bladder and the sphincter, the worker bees, are down in the pelvis. So the spinal cord is a critical pathway in that it takes messages back and forth. It takes messages from the bladder and sphincter to the brain, and from the brain to the bladder and the sphincter. As you can see from this little diagram here, and it's the kind of diagram I hate, and probably a lot of you hate it as well, because it shows all these nerve pathways. But I want you to realize there are three major pathways. There's the sympathetic pathway, there's the parasympathetic pathway, and there's the pudendal pathway. We're going to look at each of those briefly, because this is how messages are transmitted. And if you have a patient who has a spinal cord injury, a spinal cord lesion from MS, from metastatic disease, that lesion is going to interfere with these pathways and is going to compromise bladder control. So look first at the sympathetic pathway. It comes off the cord. at the thoracolumbar level, so typically about T10 to L2. It's labeled H for hypogastric. That's just the name of the sympathetic nerve. But here's what I want you to notice. I don't want you to get lost in all the details, but I want you to notice that when you follow this pathway out, the primary innervation is at the level of the bladder neck. Secondary innervation is at the level of the bladder wall. And what did we say happens with sympathetic stimulation? Sympathetic stimulation causes bladder wall relaxation and bladder neck contraction. A good way to remember that is to remember sympathetic stores. So sympathetic pathways are active during the storage phase. So when the pontine storage center is in control, it's activating these sympathetic pathways. It's sending messages down the sympathetic pathways to keep the bladder wall relaxed and the bladder neck tight. And the primary neurotransmitters for the sympathetic nervous system are epinephrine and norepinephrine. Now, in a little while, we're going to talk about medications that are used to help manage voiding dysfunction and incontinence. And you can see that if we had a medication that effectively reproduced the effects of the sympathetic nerve pathways during the storage phase, it could promote continence. It would be great if we had a medication that reliably tightened the bladder neck and relaxed the bladder wall, and that was safe for use. At this point in time, there is no medication that is FDA approved that replicates sympathetic nervous system activity. There is not an alpha adrenergic agonist / sympathomimetic. There are two medications that are sometimes used. One is pseudoephedrine, which has major sympathomimetic effects. Unfortunately, in addition to tightening the bladder neck, Sudafed causes tachycardia and can cause hypertension. So it's not very widely used, and when it is used, it's off-label. Another one is duloxetine, and duloxetine was actually evaluated for possible use in management of women with stress incontinence, leakage related to activity. But they failed to do testing related to any increase in suicidal thoughts, and that's one side effect of this category of medication. So it is not FDA approved for continence care. It is only FDA approved for depression. So we have no drugs that are FDA approved for management of incontinence that manage by tightening the bladder neck and relaxing the bladder wall. Any drugs that are used off-label. Now, if I had a woman and she had depression, she was clinically depressed, and I was looking at antidepressants, and she also had problems with stress incontinence, I would definitely lean toward duloxetine, because we have data that shows that in addition to improving mood and reducing clinical depression, it also reduces episodes and volume of leakage. Okay, come down to the next pathway, the parasympathetic pathway right here. It comes off the cord at the sacral level, so S2 to S4, and you follow it, and it has one direct line to the bladder wall. So when you think about parasympathetic stimulation, you think about voiding. And sometimes we say sympathetic stores, parasympathetic Ps, because the primary effect of parasympathetic stimulation is bladder wall contraction. So when are the parasympathetic pathways going to be active? During voiding, when the pontine micturition center is in control. So if the pontine storage center is in control, sympathetic pathways will be active, bladder neck stays tight, bladder wall relaxes. If the pontine micturition center is in control, these pathways are shut down, parasympathetics are activated, and now you get bladder wall contraction and empty. Now, the primary neurotransmitter for the parasympathetic nervous system is acetylcholine. So a lot of times you'll hear people talk about cholinergic medications, medications that mimic the effects of acetylcholine, or anticholinergic medications, medications that block the effects of acetylcholine. And we'll come back to that. Now the next point on the slide is that the parasympathetic pathways are part of a reflex arc. With normal function, this reflex arc is not active and is not important. But if you lose central control, if you have a devastating stroke, if you have a spinal cord lesion, then this reflex arc can take over and control voiding. And the reflex arc involves sensory input to the cord and then the parasympathetic pathway. So sensory input regarding feeling triggers parasympathetic activation and bladder contraction. It's a very simple reflex, very much like tapping the knee and you get that deep tendon reflex, so you get the leg elevated. In this case, bladder filling triggers bladder empty. But that is important only in patients who have major neurologic issues. For the rest of us, that reflex arc is not active. The last pathway I want you to notice is the pudendal nerve pathway. The pudendal nerve is a sensory motor nerve. When you do a Kegel exercise, when you contract your pelvic floor muscles, you're using the pudendal nerve to do that. So the pudendal nerve doesn't go to the bladder at all. It goes straight to the sphincter muscle in the urethra and allows you to control the sphincter muscle. So just to summarize, everything is coordinated. When the cortex says maintain storage, the pontine storage center is activated. It maintains storage by keeping the bladder neck tight. Sympathetic pathways are active, keeping the bladder wall relaxed, so that's sympathetic stimulation. Bladder wall relaxed, bladder neck tight. Also remember that the pontine storage center activates those cells in the sacral cord on its nucleus to activate the pudendal nerve, so you get contraction of the striated sphincter. Flip it. Cortex says voiding is appropriate, initiate voiding. The pontine storage center shuts down. The pontine micturition center is activated. When the pontine micturition center is activated, the bladder wall contracts. Remember that the sympathetic system's been shut down, so the bladder neck relaxes. The pontine micturition center also shuts down on its nucleus and the pudendal nerve, so the external sphincter relaxes. Amazing coordination. Complex, kind of hard to understand at first, but pretty amazing. So it's basically an on-off. If the storage center is active, sphincters are tight, bladder wall's relaxed. If the micturition center is active, sphincters are open, and the bladder wall is contracted. Sorry, I'm having a little trouble with my little clicker. Okay, so we've talked about neural control. That's the hard part of this class, this little section. If you have questions, we totally understand that. Do not hesitate to call so that we can talk through this with you. Really critical for you to understand neural control of voiding. Okay, so thank God we're out of the neurologic pathways. Now we're talking about the bladder and the sphincter, which is more our comfort zone probably. So what do we know about the bladder? Well, we know that the bladder is primarily a muscle, a smooth muscle, also known as the detrusor muscle. But we also know that it's lined with epithelium, mostly transitional cell epithelium, some squamous. Altogether, it's known as the urothelium. And that urothelium actually has several functions. First of all, it creates a barrier between urine and all of the components in the urine and the bladder wall itself. So if there are irritants in the urine, they never reach the cells of the bladder wall because of the urothelium. It creates this mucoid layer that actually separates bladder contents from bladder wall. When we talk about interstitial cystitis, one theory as to what causes the intense pain and inflammation of interstitial cystitis is that there's damage to the urothelium and the irritants in the urine are allowed to contact the bladder wall. We need a lot more data, but that's one theory. We also know that the urothelium has active signaling molecules, so that as the bladder stretches and becomes fuller and fuller, signaling molecules activate pathways to the brain to alert the cortex via the PAG that the bladder is full. So the urothelium both protects the bladder wall, and increasingly we recognize that the urothelium plays a role in alerting the midbrain and eventually the cortex to the level of bladder filling. What about the detrusor muscle? Well, the detrusor muscle is very highly innervated. So lots of nerve cells in the bladder wall, almost a one-to-one, like nerve cell to muscle fiber. So very high level innervation. Now the bladder with normal function will sit and store, stretch, stretch, stretch. Normal adult bladder can hold up to 500 cc's or even more. If it's a nurse's bladder, probably more, without contracting. However, you should know that with increasing distension, as the bladder continues to fill, you start getting little twitches. Now, these little contractions are not enough to trigger empty, but they are enough to increase the signaling noise to the midbrain and to the cortex, to increase awareness of filling. So you know that. You know that after you void, for a period of time, you're essentially unaware of your bladder. And then as the bladder begins to fill, you become aware first just kind of as a background thing, like, oh, when I get a chance, I'll go to the bathroom. As it approaches capacity, those signals are much louder. You become much more aware of your bladder. And when it's at capacity, your bladder's about all you can think about. Your bladder and how far you are from a bathroom. So how does that happen? Well, as the bladder distends, remember those little twitches that occur. It's kind of probably the bladder muscle getting ready to contract. And the more twitches you have, the more sensory awareness you have. So the detrusor muscle itself helps to convey level of filling and need to void. Here are the two things that are absolutely critical to normal bladder function and to normal renal function. First of all, you need your bladder to stretch and store. You want a bladder that stretches easily because you want to be able to hold significant volumes of urine, at least 350 to 500 cc's, without sustaining a significant increase in filling pressure. Let me explain why. Remember, the kidneys are constantly making urine, and they're propelling urine down the ureters into the bladder. So the ureters have active peristaltic activity, but it's a very low pressure system. Normally, pressures within the ureters are higher than pressures within the bladder because normally the bladder is a very low pressure system. But if the pressures in the bladder rise to a level that is greater than the pressures in the ureters, it will shut down urine delivery. If you shut down urine delivery, you start to get a lot of back pressure on the kidneys and hydronephrosis and eventual renal damage. So critical to have a bladder that's nice and stretchy. You want it to be able to stretch and store without causing a significant increase in bladder pressure. Sometimes I compare it to, those two different kinds of balloons you can get. So you can get those very long, thin balloons, or you can get those big fat round balloons, and the fat round balloons are easy to blow up. It doesn't take much pressure to blow that balloon up. That's what you want your bladder to act like. You do not want it to be like one of those long skinny balloons, because you have to just about pop your eyes out of your head and you still don't have significant filling of the balloon. So having a bladder wall that's stretchy helps to maintain renal health. It also provides you normal capacity. If you have a bladder wall that's very scarred, very fibrotic, it can't stretch and store, then two things happen. First of all, your capacity is significantly reduced, and low volumes of urine cause intense urgency and frequency. And secondly, as we've said, as the bladder fills, the pressures rise rapidly and create back pressure on the kidneys. So a stretchy bladder, critical. And that's sometimes known as bladder compliance, just so you know. Those of you who have worked a lot with ventilators, you're very familiar with the term compliance as it relates to the lungs. It means the same thing when it comes to the bladder. Now, the second thing we need the bladder to be able to do is we want it to contract effectively to empty. So let's say you have 500 cc's in your bladder, or maybe 600, and you finally get to the bathroom. How much of that do you want to void? Every bit, right? You want it all to empty out so that you leave the bathroom at 0 milliliters, so that you have full storage left to you. If you go in the bathroom with 600 milliliters and you leave with 300, you're half full and you don't have much capacity left. So really important for the bladder to contract effectively to empty. So you want a bladder that stretches and stores. You want a bladder that contracts to empty. Normally, the bladder is very well behaved. I mean, we pretty much abuse our bladders, most of us, on a daily basis. We do all kinds of things to it. We make it hold more urine than it wants to hold because it's not convenient, because we're in a patient's room, because whatever. Sometimes we ask it to void when it has no urge to void. There's very little urine in the bladder, but we figure it's our best chance because we're going to make several home visits and there's no place to go, or because we're going to be in a very long meeting. So we get it up when it's sound asleep and say, get up and empty, and we make it hold urine way past its comfort zone. But most of the time, the bladder is very well behaved. It does exactly what we ask it to do, exactly what the cortex says. It either gets up and empties or it sits and stores. But if the bladder is inflamed, either because of infection, because of an indwelling catheter, a large balloon, impaction, then it behaves totally differently. So most of you have had a urinary tract infection. And you know that when you have a urinary tract infection, you have intense frequency and urgency, because the irritants in the urine sensitize the stretch receptors in the bladder wall and make the bladder much more contractile, much twitchier. It's like a spasm. So even though the bladder is normally well behaved, we have to realize that when the bladder is inflamed, it acts like any inflamed muscle. It's very prone to spasms. It's much less able to carry out normal function, stretch and store. Okay, now we're down to the sphincter. What do you want from your sphincter? So I know as a nurse you want a bladder that holds a lot, 700, 800, maybe 900 cc's. You want a bladder that contracts effectively so that when you leave the bathroom you're empty and you don't have to go back for a while. And what do you expect of your sphincter? Well, you want your sphincters to stay closed and tight so you don't leak, right? Well, what about if your bladder's full? Should your sphincter still maintain complete closure? Absolutely, right? You don't want any leakage just because you're full. Is it okay for you to leak if you're jumping or laughing or coughing or sneezing? No. We want a sphincter that stays closed throughout the storage phase, completely closed. No drips, no leaks. Full bladder, we still want it closed. No drips, no leaks. Full bladder and I'm coughing or sneezing or lifting, I still want my sphincter to stay closed. And then when I go to void, what do I want my sphincter to do? I want it to swing wide open. So I want a very well-behaved faucet. A faucet that is off when it's off and on when it's on. So let's talk about the anatomic and physiologic features that contribute to optimal sphincter function. Now we know that men are much less prone to incontinence. You rarely hear a man say, I don't know if I've ever heard a man say, don't make me laugh, I'll wet my pants. I've heard lots of women say that, and I've said it. But I don't hear my husband say that, and I don't hear other men say that. And that's partly because of anatomical differences that significantly increase their level of urethral resistance. So first of all, the male urethra is longer, and the longer the tube, the greater the resistance. And secondly, you've got two right angles. So anytime you add angles to a pathway, you increase resistance. So urethral length, urethral curvatures markedly increase urethral resistance in the male. You also have the prostate gland that provides passive support for continence throughout most of their lives. Now you know that late in life, when the prostate gland tends to enlarge, that many men develop voiding dysfunction. They develop some degree of urinary retention. So they're actually higher risk for urinary retention than women, but lower risk for incontinence. What are other features of the urethra and the sphincter mechanism that contribute to continence? Well, there's a submucosal vascular cushion, and you can see it here. And that submucosal vascular cushion acts as a fluid-filled sponge that surrounds the urethra. And when you contract the sphincter muscle, that fluid-filled sponge helps to transmit contractile pressures to the urethra. So that's particularly important for women because we don't have length and we don't have curvatures. We have a short, straight urethra. So that submucosal cushion plays a more important role, helping to maintain urethral closure during times when I'm coughing, laughing, sneezing, or my bladder's full. But notice that the thickness of that vascular cushion is partially estrogen dependent. So even though it's very thick and plump and fluid filled during premenopausal years, during postmenopausal years, that cushion thins and provides less support. And that can be not the causative factor, but a contributing factor to leakage in postmenopausal women. Another factor particularly important to women is urethral coaptation. Now what does that mean? It means that the urethral walls are normally very soft and very sticky. They tend to collapse against each other. And it takes a lot of force normally to open them for urine to pass through. Now that stickiness is created in part by mucus that is secreted by the suburethral glands. Unfortunately, mucus production and urethral wall coaptation is also partially estrogen dependent, so it is diminished postmenopausally. So we see a marked increase in complaints of stress incontinence leakage with activity in postmenopausal women. Loss of estrogen and the negative impact on that submucosal vascular cushion and on urethral coaptation can be a contributing factor, never the causative factor, but a contributing factor. Well, what about the sphincters themselves? So we've already talked briefly about the fact that the bladder neck is a component of the sphincter mechanism, and it is controlled by the autonomic nervous system. So whenever you're in storage mode, the bladder neck is tight. When you're in empty mode, the bladder neck is open. A much more critical component of continence is the voluntary striated sphincter mechanism. Now I wanted to show you where it's located. You have both a circumferential sphincter muscle that's located within the wall of the urethra, and then you have periurethral muscles, and they work as a unit. So in the male, I want you to see right here, the striated sphincter is located right below the prostate gland. It's sometimes called the rhabdosphincter, so right below the prostate gland. So you can see that in a male who required radical prostatectomy, and they removed this section of the urethra and then mobilized the distal urethra for anastomosis to the bladder neck, you can see that there could be some temporary or long-term damage to that voluntary sphincter mechanism. In women, voluntary sphincter mechanism located right here, about 2/3 of the distance down from the bladder neck. That is the component that is under voluntary control. So when you're teaching patients how to do pelvic muscle or Kegel exercises, you're teaching them to exercise this muscle and all of the periurethral muscles. Now, in looking at the voluntary sphincter muscles, they contain both slow twitch and fast twitch fibers. About 2/3 of the muscle fibers are slow twitch. Slow twitch fibers maintain sustained resistance. They use oxygen slowly. They fatigue very slowly, so they're very well equipped to provide sustained closure. So 2/3 of the muscle fibers are those slow twitch. That's great. That gives you continence at rest when you're not even thinking about it. But notice that 1/3 of the muscle fibers are fast twitch. So when your bladder's really full and you're trying to make it to the bathroom and you contract your pelvic floor muscles, you do a Kegel exercise. If you're about to sneeze or cough and you engage your pelvic floor, now you're engaging the fast twitch fibers. So 1/3 of your fibers are fast twitch. They give you a rapid, marked increase in contractility and in urethral closure. So you think of your slow twitch, they're kind of your steady state, maintaining closure when you're walking around doing things. You think of your fast twitch, those are the rapid response guys. They rush in and increase urethral closure pressure when you most need it. So 2/3, 1/3. Also, you should know about something called the guarding reflex. So as the bladder fills and filling pressures start to rise, you get a corresponding reflex increase in pelvic muscle tone. So it's like bladder pressures are going up, that's okay. Urethral pressures are going up as well. The key thing, of course, you want urethral pressures to be higher than bladder pressures during the storage phase. You want bladder pressures to be higher during the emptying phase. So see how well tuned this whole mechanism is? As your bladder fills, bladder pressures go up, urethral pressures go up. That's the guarding reflex. In women, pelvic floor support is a very important component of continence. Now, this is not so important to men, but very, very important to women, because you think of the multiple or the sustained effects of gravity on pelvic structures. And what you get over time, you can get a bladder that is not well supported. It's really not in position. This is affected significantly by pregnancy and by childbirth. So let's go over normal function. Let's go over what can go wrong. So when we talk about the pelvic floor, what is that? Well, it is a combination of structures. You've got muscles, you've got ligaments that help to maintain the bladder neck, the vagina, all in appropriate position. As long as the bladder stays in position and the urethra stays in position, you get optimal sphincter function. Because remember, what is the sphincter muscle trying to do? Is trying to provide circumferential closure around the urethra. And as long as it's in position, it's very able to do that. But if it drops out of position, now it's having to reach up and reach around to try to close the urethra. So when the bladder and the urethra drop out of position, it compromises sphincter function. What does the pelvic floor do? It helps hold things in position. Now, early in life, during childhood, teen years, early adult years, I apologize, the pelvic floor acts very much like a trampoline. So if you get downward pressure on the bladder from straining, from coughing, from laughing, from serving a tennis ball, the pelvic floor pushes right back. So you push down, it pushes back, everything stays in position. That's exactly what you want. But as time goes on and those muscles become more stretched and the ligaments become more stretched, it acts more like a hammock. And so you cough or laugh or sneeze or bear down, and instead of the pelvic floor pushing back, it just gives way. And that level of relaxation can become progressively worse. That is another contributing factor to leakage during activity, to stress incontinence in women. Because think about this. Let's say I'm postmenopausal. I've had several vaginal deliveries, so my pelvic floor has definitely been stressed at various points. And now when I go to the gym, I notice that I leak when I'm jumping. What's going on? I didn't leak 10 years ago, but I'm leaking now. And it's probably a combination of things. First of all, now I'm postmenopausal, so my vascular cushion isn't as thick and plump and doesn't convey pressures as effectively as it did 10 years ago. Secondly, my pelvic floor is more lax than it was 10 years ago, and so when I'm jumping and I get downward pressure, instead of getting a push back, my pelvic floor gives way. Loss of estrogen also makes the urethral walls less sticky. So those things can work together to cause leakage during periods of increased activity. Now, can we do anything about it? Yes, because we can strengthen the sphincter muscles and we can strengthen the pelvic floor. We can also do a trial of topical estrogen to see if that makes a difference. So my point is that for most people, problems with incontinence, there's multiple contributing factors, and it's not just one thing that corrects the problem. It's looking at it multidimensionally, correcting all of the potential contributing factors that takes that person out of pads and back into her previous function as being continent, even at the gym. Now, mid-urethral support seems to be particularly important. There is a pubourethral ligament that actually anchors the urethra to the symphysis pubis, and that helps to stabilize the urethra. So again, you want the urethra in position. If the urethra is held in position, the sphincter is held in position. That allows the sphincter to contract circumferentially and close the urethra effectively. So we've talked about the importance of neural control. We've talked about the importance of normal bladder function, the ability to stretch and store at low pressures, the ability to contract and empty effectively. We've talked about the importance of sphincter function, that you want a sphincter that stays closed during the storage phase, swings open during the emptying phase. We've talked about different factors that impact on sphincter function in men and women. So what do men have? They have urethral length, they have curvatures. They have the prostate gland. They have the smooth muscle in the bladder neck, and they have the striated muscle just below the prostate. They also have those sticky urethral walls. It's just less critical to them. So we said men, very low risk for incontinence unless they require radical prostatectomy, in which case they may have issues because now the surgical procedure has potentially caused damage to their voluntary sphincter mechanism. We've said women have a short, straight urethra. They do have that submucosal vascular cushion. They do have urethral coaptation, those sticky urethral walls. But that stickiness and the thickness of the vascular cushion can be somewhat diminished postmenopausally, which can be a contributing factor to incontinence. We've said a critical aspect of continence for both men and women is normal function of the striated sphincter mechanism. Located just below the prostate in men, about 2/3 the distance down in women. You've got a muscle within the urethral wall that connects in turn to periurethral muscles and the pelvic floor. Normally, that sphincter mechanism maintains urethral closure throughout the storage phase. If you have a patient who's leaking urine during activity, one of the things you can teach them is how to strengthen the muscle by doing pelvic muscle exercises. We also talked about the importance of pelvic floor support for women. So in women, for women, continence is dependent on the submucosal vascular cushion, urethral coaptation, normal sphincter function, and pelvic floor support to keep the urethra and the sphincter in position. Now we're going to talk about what happens with the aging process. And I want to start by saying incontinence is never normal. I don't want to be incontinent just because I'm 75. I want to be continent until I die, essentially, and I think that's what most people want. But we have to realize that aging does cause a number of changes in bladder function that can impact on continence, and we have to take these into consideration when we're assessing our patients. So first of all, we know that older people make more of their urine at night. Young people rarely get up at night to void, whereas it's very common and considered normal for people over 65 to get up once or twice a night to void. And that's partly because with aging we produce less ADH at night, and so we don't concentrate our urine as well at night, and we actually produce more urine at night. So nocturia is considered normal for older individuals, but it can also be very frustrating for them, and it can interrupt their normal sleep cycle, which has a number of other negative effects. So there's actually a lot of research ongoing now looking at nocturia and the factors that cause nocturia and best management. Second thing that happens is the bladder loses some of its stretchiness, some of its ability to store urine at low pressures, which is not unusual because if you look at muscles throughout the body, their function tends to deteriorate with age. So what this translates to when we look at bladder function is someone who held 500 to 600 cc's when they were younger may only hold 400 cc's now. Someone who held 400 cc's may only hold 250. So you can see that that directly translates to increased frequency. The third thing is that the bladder doesn't contract as effectively. Again, just look at normal changes in muscle function. So it's common for people to have some degree of post-void residual. And that, again, translates into increased frequency. Not anything that's abnormal. You think about what happens with the heart, what happens with the ejection fraction. Well, that deteriorates with aging as well. but certainly something that has to be considered when we establish bladder programs and management programs for elders. And certainly we want to be sensitive to how frustrating it is for someone to have increased urgency, increased frequency. That takes us to the last point, increased irritability of the detrusor muscle. So things are much more likely to cause leakage when you're older than they did when you were younger. Running water might cause leakage for someone in their 70s or 80s, but it didn't when they were in their 40s or 50s. It's that detrusor muscle being much more responsive to irritants. So what we hear from our patients is, I have to go more often than I used to. I don't empty as effectively as I used to. I'm not sure I empty all the way. And sometimes I'm afraid I'm not going to make it. Additional changes that occur with aging is a delay in recognition of bladder filling. That has to do with diminished sensory neurotransmitters. So they might not recognize bladder filling until they're right at capacity. This can be really frustrating for them and for their caregivers. So I don't know if you've ever seen this happen. I know I've seen it happen where maybe the CNA goes in and says to the patient, do you need to go to the bathroom? I'm here, I can take you to the bathroom now. No, I don't have to go. Are you sure? Because I'm here. No, I don't have to go. And then 5 minutes later, what happens? The light comes on. I have to go to the bathroom. So the CNA, unless he or she has been educated, is probably frustrated and irritated and thinking that that patient is being disrespectful of their time, when in fact the patient was telling the truth. They had no urge to void when you were there, and now they have intense urge to void. So I sometimes, when I'm trying to help caregivers understand, I compare it to hearing loss. So people with normal hearing, you can just talk in a normal tone of voice, they hear what you say. But if you have an older person with hearing loss, you have to speak much louder. You have to increase the volume for the message to get through. Much the same thing in looking at communicating the message from the bladder to the brain. So a simple solution is, don't ask the person if they need to void. Ask the person to try to void. Say, I'm going to get you up to the bathroom. I want to see if you can urinate in the toilet. Well, I don't have to go. I know, I just want you to give it your best shot. And then you think about reduced mobility is a huge issue for many elders. So just take the last two things we've talked about and think about the link to incontinent episodes. What if I don't get the message that my bladder's full until I'm at capacity, and I have reduced mobility, so it takes me a little while to get out of the chair, and then I have to use my cane or my walker to get over to the bathroom? You can see that I'm much higher risk for incontinent episodes, and that putting me on a toileting schedule could make a huge difference. So void by the clock, not by the urge. We also have to consider the effects of medications. We're going to talk more about that as we go into assessment. I'm going to talk about it in just a minute in terms of big picture. And then, as we've already mentioned, women are dealing with the effects of reduced estrogen, and men are potentially dealing with the effects of an enlarged prostate gland. So the last thing I wanted to cover here is medication terminology, because you're going to encounter this as we go through assessment and management. We've talked about how important the autonomic nervous system, the sympathetic and the parasympathetic nervous system, are to bladder function and to continence. So it makes sense that we would be looking to see, are there medications that we can use to improve function during the filling phase, to improve function during the emptying phase. And there are, as you see on this slide, 4 categories of medications that could conceivably be used to improve bladder function, to improve continence. You'll also see that 2 are in bold, and those are the 2 I want you to focus on. So we'll start from the top, but we'll focus on the 2 in bold. So first of all, we said during the storage phase, the sympathetic pathways are in charge. The sympathetic pathways are active. They're maintaining urethral closure, bladder neck closure, bladder wall relaxation. So it seems as if we had a medication that was sympathomimetic in nature, meaning it mimics the effects of the sympathetic nervous system, that could be beneficial, that it could promote storage. It could reduce the incidence of leakage. So when you hear the terms sympathomimetic or alpha-adrenergic, you want to think storage phase. So sympathomimetic means mimics the effects of the sympathetic nervous system. Alpha-adrenergic agonist means mimics the effects of the sympathetic nervous system, specifically the effects of alpha-adrenergic stimulation. What does sympathetic stimulation, specifically stimulation of the alpha-adrenergic receptors, provide? Tightening of the bladder neck, reduced leakage, right? So that would be beneficial for people who tended to leak with activity. Why is it not in bold? Because at this time we do not have any medications that are FDA approved for management of stress incontinence, urinary leakage with activity. So theoretically, that could be beneficial. At this point in time, it's not a realistic option. But what about alpha-adrenergic antagonist? Now, if alpha-adrenergic agonists increase urethral resistance, alpha-adrenergic antagonists are going to reduce urethral resistance. That's going to be beneficial in the patient who has problems during the emptying phase. It's going to be beneficial for that male with an enlarged prostate gland. And in fact, that's exactly when we use alpha-adrenergic antagonist, is for men with prostate enlargement and difficulty emptying. So how many of you have given tamsulosin Flomax? So that's an alpha-adrenergic antagonist. Third category, cholinergic, means it mimics the effects of acetylcholine. Acetylcholine, the primary neurotransmitter for the parasympathetic nervous system. Parasympathetic nervous system active during the emptying phase, the voiding phase of the cycle. So theoretically, a cholinergic agent, which could increase bladder contractility, would be beneficial for a patient who had incomplete emptying. And there have been cholinergic agents introduced in your handout. Bethanechol, urocholine is mentioned. However, none of these medications have proven effective. So we do not routinely use cholinergic agents. If we get an effective cholinergic agent, there are definitely patients who could benefit. Anticholinergic agents are very widely used. So you think cholinergic agents increase bladder contractility. Anticholinergic agents will diminish bladder contractility. They will reduce urgency. They will reduce frequency. They will improve the bladder's ability to stretch and store. So things like ditropin and detrol and sulfenacin, many new anticholinergics on the market. So very widely used. So when you're studying medications, focus primarily on alpha-adrenergic antagonists, which improve emptying, and on anticholinergics, which reduce urgency and frequency. Okay, so in summary, and I bet you would agree with point number one, continence and voiding are complex functions. They're not as simple as we may have thought. When we're doing assessment for any patient with problems with leakage or problems with emptying, we have to assess sphincter function, we have to assess bladder function, but we also have to assess neural control. So we can't ever forget that third component, neural control. In the end, to have normal function during the storage phase, you have to have urethral pressures that are higher than bladder pressures. The bladder's the reservoir, the urethra is the outlet. If I'm storing effectively, the outlet is closed and the pressures in the outlet are higher than the pressures in the reservoir. But during the emptying phase, everything flips around. Now the bladder's contracting and the pressures within the bladder should be higher than the pressures within the urethra. So that's the end of this session. I know we've thrown a lot at you, but we will come back and we will reinforce this, because in the next session we're going to talk about the different types of incontinence and voiding dysfunction. Then we're going to talk about assessment, and then we're going to talk about management. So this was just laying the groundwork and probably seeding or sowing the seeds of confusion, and then we're going to come back and we're going to try to clarify over and over again. Thank you.